session, I wouldn't be showing you brilliance or rare cases, difficult ones. Rather, I would be going through the cases to show how you can handle some cases safely during work. Moreover, how to score in the exam. So please let me just take you for an overview for the session. We have 12 cases for the 4 candidates, 3 cases per candidate. So we expect candidates to have like 10 minutes for each case. Of course, I will take 1 or 2 minutes out of these 10 to go over the case after the candidate is over. So I'm expecting the candidate to go over the case for like 8, maximum 9 minutes, which is more than enough, I believe, for the case. Candidate number 1, are you with us?
Yes, sir. Good evening, sir.
Good evening. How are you doing? Fine?
Fine, sir.
Yes. Can you see my screen now, right?
Yeah, I can see, sir. MRI brain images are there. Yeah.
Okay, perfect. So I have this patient for you. I will switch the screen so you can start with the case. Okay, can you see the brain CT scan now, right?
Yeah, now I can see the brain CT scan images.
Yes, please request using the mouse. So,
Yes, sir. I requested for the remote control.
yeah, yes, okay, now approved. Yes. Okay, so this is a brain CT scan for a patient who came with decreased level of consciousness. Please go through it and tell me your findings.
Sir, upside downside arrow.
Yes.
Yeah.
Uh,
So here I am presented with the non-contrast CT scan, brain window, axial sections, patient presented with decrease in consciousness. So I am checking towards the posterior part of the brain, um, and I am scrolling from first cut to last cut. The area of concern in this condition, the area affecting the reticular activating system, I am checking at there is no evidence of any. I am looking at the basilar artery. Uh,
mhm.
there is no evidence of basilar artery hyperdensity is there. Mm, Then the left transverse sinus looking slightly hyperdense to me.
Okay.
There is no evidence of any tonsillar herniation, no evidence of any hemorrhage, no evidence of any hydrocephalus in the present scan. No, there is some hypodensities are also seen in the uh, left frontoparietal region. Uh,
Mhm.
um, uh, However, there is no evidence of any significant midline shift is there, no evidence of any hyperdense vessel sign is there.
Okay,
So,
okay,
in
what would you do?
in my routine practice, I will check the uh, I will check it in the stroke window,
Mhm.
which is
Okay,
the
so
window.
window revealed nothing much than what you've already described, and so what else?
Yeah. So, if the patient is on the table, then I will go for the contrast images to rule out this what is happening in this
Mhm.
hypodense area. There
Yeah.
may be, yeah.
Mhm. The patient actually is allergic to iron contrast, and this option is not valid at the moment. So
Yeah.
anything else?
We will proceed with the MRI brain.
MRI. Okay. We have MRI, I believe. So just I will switch to it. Give me just 1 second, please. Okay, which sequence do you want, would you like to start with?
I want to see the T2 weighted images. I want to see the again the phloboids and the hypodense area in the. area of
This
concern.
T2L images, can you see it?
Yeah, I can see these are the MRI brain,
Yes.
T2 weighted images, axial sections. I am scrolling from down to upward. I am, yeah, the basilar artery is okay. There is no problem with the basilar artery.
Mhm.
And the area which was hypodense on the CT scan, that is corresponding to hyperdensity in the cortical subcortical region, uh, in the left frontoparietal lobe. Uh, and I want to see the I want to see the T1 weighted images and the diffusion and post contrast images as well.
Okay. So diffusion, let me please upload diffusion for you. Um, yes, this is diffusion. Can scroll through it. So does it show anything significant in the diffusion?
No, I will correlate with the ADC values also, but there is no significant diffusion restriction is there.
Okay, so what else would you like to look at in the images of brain MRI?
Yeah, so I want to see the flare images,
Which sequence?
flare images, fluid attenuated flare
Flare.
image. Yeah.
Yes, this is a flare.
So on the flare images, this is hyperintense on the flare weighted images in the cortical subcortical region, and there is few prominent phloboids are also there. They are traveling in the convexity of the temporal lobe. Yeah, and I want to check the left transverse sinus phloboid again on the T1 weighted images. Is there to rule out any thrombus is there in the left transverse sinus?
Mhm. Okay, so flare images, or do you want another sequence for that?
I want to see the T1 weighted images, or in the T2 weighted images, I want to check the again the left transverse sinus.
Yes, this is T1 weighted images.
Yeah, on the T1 weighted images,
Mhm.
there is slight hyperdensity there in the left transverse sinus on the T1 weighted
Mhm.
images. That can be thrombus. I
Mhm.
want to see again the T2 weighted images to loss of loboid is there, or post contrast images if available, or the
Okay,
MRV. Yeah,
okay. These are the post contrast images. Can scroll through them.
yeah, yeah. On the post contrast images, yeah, on the post contrast images, there is a hypodense, hypointense filling defect is noted in the left transverse sinus. So that is dural venous sinus thrombosis. And apart from this, I can see in the post contrast images there is significant hyperintensity is noted along the sulcal spaces in left frontoparietal lobe. Apart from this, there is a pachymeningeal enhancement is there.
Mhm.
So
So, what
so
about the transverse sinus? You said you want to check the transverse sinus. How do you find it in these images?
in the transverse sinuses, the
Mhm.
um, so actually These leptomeningeal and pachymeningeal enhancement can be due to some infective pathology, or if the patient is a some non-case of some primary, then this can be due to leptomeningeal metastasis. These can be due to the sarcoidosis as well. And
Mm-hmm.
the left transverse sinus is, um, there is some central filling defect is there. However, there is no mastoiditis, no sinusitis, but it
Okay.
can be due to transverse sinus, left transverse sinus thrombosis. If there is any predisposing conditions, are there some infection, dehydration, that can lead to the transverse sinus thrombosis.
Okay. So would you please conclude the findings so far and what's your preliminary diagnosis?
Uh, in summary, there is a in the left transverse sinus and the left sigmoid sinus, uh, there is a filling defect. So dural venous sinus thrombosis is there, and that can be due to some infective pathology that is going on, that is showing leptomeningeal and pachymeningeal enhancement. Uh,
Mm-hmm.
so, however, there is no significant diffusion restriction is there, no evidence of any abscess formation or no ventriculitis is there. So
Okay.
this is a urgent finding. I will immediately pick up my phone, and urgent neurology referral is indicated, and MR venography and anticoagulation should be started.
Mm-hmm. So any differential diagnosis other than infectious pathology?
Malignancy can be one possibility. That if there is a non-case of the primary, then the leptomeningeal and the pachymeningeal metastasis can occur, and the malignancy can predispose to the dural venous sinus thrombosis as well.
Okay. Okay. So um, let me show you this additional image. Um, okay. This is MRV source images. Okay. I believe you can scroll through them. Since you mentioned that it could be a transverse sinus thrombosis, yes, we thought the same. That's why we proceeded for MRV. Okay, so what do you think?
Yeah, on the right transverse sinus is in an the right transverse, on the left transverse sinus,
Mhm.
there is a filling defect is there on the left side.
Yes. So,
So this is left transverse sinus thrombosis.
okay. Can you tell us if it extends to somewhere else as well? Does it involve other venous sinuses? Can you go through it?
Yeah.
Yeah. Okay. So, what's your final diagnosis now?
Um, this is left transverse sinus as well as the left side internal jugular vein, that is also
Mm-hmm.
there is some filling defect is there in the left internal jugular vein is there.
Mm-hmm.
So summing up all these finding,
Mm-hmm.
the dural venous sinus thrombosis with, um, due to some infective pathology, cerebritis is going on. Cerebritis,
Okay.
yeah, cerebritis in the left frontoparietal lobe with dural venous sinus thrombosis.
Okay. Okay, perfect. So please let me take over. I will change the screen. Okay. Now, can you see screen written candidate one, case one, right?
Yeah, yeah, I can see.
Okay, so this is the CT scan that was shown and the at first. Okay, you could spot the left transverse sinus that is hyperdense relative to the rest of the sinuses. Moreover, there is a cortical superficial vein that is also hyperdense, as seen on the right side image. This is called the dense vein sign or the cold sign, depending on how do you view it or how do you name it. So this means there is increased density of the venous sinuses or the cortical vein, which indicates a pathology. The pathology in this case is a thrombosis. So if you look, this is the stroke window that you asked for, and you could also spot that there is hypodensity in the left frontoparietal region with loss of gray-white matter differentiation in this area. So it indicates also that there is a pathology going on in the brain parenchyma. So if you sum these two things up together, you will end up an a preliminary diagnosis of venous sinus thrombosis causing a venous infarction in this area. So if you look at it in the brain MRI, these are the sequences that matter much for you. There is a hypointensity one-weighted signal in the cortical subcortical white matter of the left frontal parietal lobe, with corresponding hyperintense signal in T2 and the flare images as you could see. There is only subtle hyperintense signal in the flare images with corresponding low signal in ADC, which is only mild restricted diffusion. And this is maybe because the patient was scanned immediately at the presentations, just hyperacute ischemic insult in there. So, post-contrast images, as you could see, there is some leptomeningeal enhancement going on, which also indicates the presence of a ischemic pathology. However, in cases where there is venous thrombosis and venous infarct, the behavior of the brain in the MRI and CT scan will be slightly different from from that in the arterial insult. So you can see some leptomeningeal enhancement earlier than arterial insult. In arterial insult, the leptomeningeal enhancement or this kind of enhancement happens in the subacute stage rather than in the acute. In the venous infarct, it is earlier, and it also can indicate some congested cortical veins to compensate for the thrombosed cortical veins and the transverse sinus that already mentioned. As you can see here in the T2 images as well, you could see the dilated signal void, which is also very important to see in the SWI or gradient echo images. This is very sensitive sequence for detection of a blood thrombus and calcifications. In such a case, you can see blooming of the thrombosed vein, which is here the cortical vein or superficial cortical vein, as well as the transverse sinus here and the internal jugular vein. The MRV images, the source images, and here are the source images of the MRV as well. They show a filling defect in the cortical superficial vein and transverse sinus, sigmoid sinus, and internal jugular vein. So this is a case of venous sinus thrombosis leading to venous infarct. So it's important to mention even during your description that this infarct doesn't correspond to territorial or arterial territory. It's important to differentiate this kind of infarction from the arterial infarct or ischemic infarct. It's also important to investigate for any hemorrhagic components, as these infarcts have a tendency to bleed even before going into treatment. So this is very important actually to spot any hemorrhagic foci. What do you think you can see the hemorrhagic foci, and which sequence is better for you to detect?
Susceptivated imaging, SWI images.
Yes, as well as the T1 images. Both of them, they will help you. After you conclude your case, you should look for complications as well of the infarct in general, especially in venous infarcts, like raised ICP, raised intracranial pressure. Yeah, you can check for effacement of ventricles, brain herniation, loss of gray-white matter differentiation, and you've done that, and you already done that, and yeah, there was in this case no effacement of ventricles or brain herniation. There was only loss of gray-white matter differentiation. So to conclude, this is a case of venous sinus thrombosis with hemorrhagic, with venous infarct in the frontoparietal lobe. Okay,
Okay.
so we will go for case number 2. Okay, case number 2. Uh, okay, so this is a patient who came with back pain. I will share it with you. As you know, those patients who come with back pain, at first they go for radiographs. Can you see the radiograph here, the lateral radiograph?
Yeah, here I am presented with the lateral radiograph of lumbosacral spine. Um, there is a patient presented with the back pain, and I am going through my checklist. There
Mhm,
is some sclerotic changes are there in the vertebral bodies. However, vertebral height looks normal. Intervertebral disc appear normal.
mhm.
Uh, no evidence of vertebral scalloping is there. No evidence of any antrolisthesis or retrolisthesis is there. Uh,
Okay.
and no obvious calcifications in the prevertebral region.
Mhm.
Uh,
Okay,
mm,
so it looks normal to you.
yeah.
Any pathologies in there? Any findings?
Mm, uh, in this, the posterior elements of the L4 vertebral bodies look slightly sclerotic to me and
Skip.
slightly.
Yeah, skip that.
Yeah.
Anything else?
Apart from this,
Okay,
uh,
so the patient complains of low back pain. Radiographs appear normal. What's
mm,
next?
uh, go with the MRI of the spine,
Okay, this is the MRI of the spine. Which sequence would you like to start with?
size T2 images.
T2 images. Okay, these are the T2 images. You can scroll through them. Can you scroll through them? Yes, perfect.
Yeah. Yeah. These are the sagittal T2 weighted images. Um, uh, Here I can see that the vertebral bodies are showing heterogeneous signal intensities at the multiple level, and there is a prevertebral soft tissue component is there in the subligamentous region at level of L5 S1. Um, there is cord appear normal, no evidence of any significant epidural collection is there.
Mhm.
No evidence of any cauda equina syndrome or cord compression is there. I am scrolling from, I can see that other bones are also heterogeneous signal intensities are there, and some enlarged lymph nodes are also there.
Okay, so what's your next step?
I want to see the check the axial sections.
Okay, these are the axial T2 images. Allow me to bring it to you. Okay, you can scroll through them.
So there is a multiloculated prevertebral subligamentous collection is there, mild action extension of the in the anterior epidural space as well.
Right. Okay, anything else?
Yeah, I'm trying to go at uppercuts. I want to go at uppercuts of the vertebral bodies.
Yeah, this is the highest
Okay,
available axial images. Okay, so the level of the kidneys. This is the L1 or T12, let's say. Okay, so
so I want to see the T1 weighted images as well.
sure. Okay,
In the yeah, sagittal section.
okay. So
So
while you are scrolling through this, sagittal T1, please conclude your findings and tell me what are your differential diagnoses.
yeah, and the L5S1 bone marrow is showing edema and some destructive changes with subligamentous collection is there. So this can be part of the spondylodiscitis.
Okay.
And there is mild epidural collection is there,
Mhm.
but there is no significant cauda equina nerve root compression. And the uh, I want to see
Okay.
the post contrast images as well. And the
Okay. These are the post contrast images.
yeah, on the post contrast images, there is a peripheral enhancement is there,
Mhm.
so that is suggestive of abscess formation. Um, and there is
Okay.
a multiple level involvement is there in the vertebral bodies.
Mhm.
Uh, So this multiple involvement, subligamentous spread,
Mhm.
epidural collections.
Mhm.
So it can be due to the tubercular spondylodiscitis. That can be the one possibility. Other possibility can be the pyogenic, but here the disc involvement is very less. So that
Mhm.
is downgrade. And
Right.
um,
So, what would you do in such a case?
yeah, in there is a urgent referral to the spinal team
Mhm.
and interventional radiology referral also.
Mhm.
The CT guided drainage of the abscess
Mhm.
can be done and culture sensitivity and appropriate anti-tubercular therapy if it positive for the acid fast bacilli that
Mhm.
can be done.
Mhm.
And the patient need isolation, admission, and I will also check for any previous chest X-ray if available, or um, to look for any cavitation or tree inward appearance,
Yes.
and information to the health authorities if tuberculosis, pulmonary tuberculosis is positive.
Okay, that's a great. So, to summarize the case, I would like to take just a second and share a few things. Okay, for the lateral radiograph, there is some soft tissue opacity anterior to L5 and S1 vertebrae. It's very subtle and it's very difficult to detect it. But if you go retrospectively from the images of MRI back to the radiographs, you can probably see some opacity anterior to these vertebrae. So it was very subtle, I agree. So in T1, this is T2, this is a steer, and this is T1 fat post contrast. You can see the collections in there. This is hypointense in T1, hyperintense in T2, well enhanced steer images with peripheral enhancement in post contrast images. So this is paravertebral collection, exactly the way that you described. Also, this triangular region shows hypointensity one-way signal and hyperintensity two-way and stair signal with some enhancement as well. However, this is not part of the infectious process. This is part of edema in the bones. So if you look at these areas, you probably can see some other findings similar to that in different bones, like in this area, and here and there. So just the way that you could see, there are multifocal marrow edema. So this is subligamentous extension. Discs are relatively spared with multifocal edema, let's say in the vertebral bodies. So this is characteristic of TB as you described. The other differential diagnosis is biogenic, which tends to involve the discs earlier than the in case into TB. Just one kind of differential diagnosis that is worth mentioning actually. If you just add it to your differential list is brucellosis. Brucellosis is one of the differential diagnoses for TB, and it behaves more or less like TB.
Yeah.
So, in general, you need, in cases of spondylodiscitis in general, regardless of the causative etiology, you should check for these findings: end-blade destruction, if there is an end-blade destruction or not, and extension into the posterior elements, actually, causing some cord compression, neural foramen narrowing, and nerve root compression. This is actually important to mention in your report, and you've done that very nicely. The one thing that you need just to add to your differentials and to your observations is presence of psoas abscess. Some infections in the spine tend to involve actually the psoas abscess as well, and I expected that from screening through the axial images to inspect the psoas muscles and the paravertebral spaces very well if there are any involvement of any muscular abscesses in there. However, you've done very well indeed in describing and concluding the case. If posterior elements are involved, in any case of spondylodiscitis, first think TB or MITS rather than biogenic. Biogenic hits the disc first, while TB has minimal disc involvement. It has skip lesions like we've seen here, and it has large paravertebral collections compared to biogenic, as also seen here. The next step of management, as you described, is isolation, checking of chest X-ray, and CT-guided drainage analysis and culture of the paravertebral collections. It's important to mention these, and these usually done by our colleagues in IR. So, Candid, when I have one more case for you, I just need a minute to upload it. Um, okay, this is a patient who presented with lower limb weakness and numbness. We had a spine spine MRI for the patient. I would like to show you, start with sagittal T2. Do you agree?
Yeah.
Okay, perfect. So this is the sagittal. You can see it now.
I
Sagittal
can.
T2.
Yeah.
Uh,
Yeah. Now I can see.
yes. Okay, you can scroll through the images. He presented. He's a young gentleman who presented with a bilateral lower limb weakness and numbness. Over to you.
Yeah. Here I am presented with MRI brain T2 weighted images, sagittal section of a young patient, lower limb weakness, numbness. So here the most significant observation I can see that there is a long segment, intramedullary hyperintensity is noted within the cord. The proximal portion is starting from the C3 vertebral body. Distal extension I cannot see. There is mild expansion of the cord as well. Apart
Mhm.
from this, there is some lesions are also there within the pons and medulla as well as in the cerebellum. Um, so I for the further characterization of the lesions, need a whole spine MRI and the MRI brain as well.
Mhm. Mhm. Um, what other sequences in the spine MRI would you like to check before ordering brain MRI? Since the patient is still on the table and uh,
Yeah,
you have the right to decide what to add for these images to reach a proper diagnosis.
I want to see the star images,
Hmm.
uh,
What
and
else?
to rule out any hemorrhage inside it, the T1 weighted images and the T1 post contrast images, because there is a marked edema is there. There may be some underlying pathology within the cord that can cause significant edema.
Okay,
And
so far, you described some hyperintensities in the bones, medulla, and cervical cord. What's your differential diagnosis at this stage?
so it is looking some systemic processes going on that is involving the brain as well as the spinal cord.
Hmm.
There may be some infectious process, or there may be some demyelinating process um,
Hmm.
that can involve like neuromyelinitis optica that involve the long segment of the cord. Um,
Yes. Yes.
and
Can this be multiple sclerosis, for example?
Yeah, multiple sclerosis, there is a cervical cord involvement, but short segment involvement is there, and predominantly the posterior columns are involved.
Right.
Yeah.
So, I would show you the post contrast images. Now you can see them. These are the post contrast images. Okay. Any enhancement? Can you spot any enhancement in there?
No significant enhancement is noted within the lesion.
Okay. So what's your next step?
So it can be some demyelinating process.
Mhm.
So I want to check the MRI brain images
Mhm.
and the MRI whole spine to look the complete extent of the cord.
Okay. Okay. So MRI images, which sequence would you like to start with?
MRI brain T2 weighted images, axial sections.
Images, yes. These are the T2 weighted images, axial, as you requested. Over to you.
So uh, here I can see that there is high signal intensity is noted on the medulla, brachium pontis,
Mhm.
pons, and yeah, there is involvement of the splenium of corpus callosum as well,
Mhm.
and bilateral basal ganglia
Mhm.
involvement is there. Uh, but the uh, 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 I am also checking the optic nerve as well. Uh, um,
Nerves are not involved in the pathology.
yeah.
So
So
what's next?
I want to check the flare images.
Okay. These are the flare images.
So in the flare images,
Mhm.
lesions, the similar lesions are seen, but I cannot see typical elliptical periventricular
Mhm.
deep white matter changes uh,
Okay.
or any black holes. I cannot see those areas, but there is some involvement of periventricular white matter is also there on the right side.
Right.
Um, and
So,
some areas on the left side as well. So,
okay.
and right thalammocapsular lesion as well. So it's a uh,
Mhm.
bilateral involvement and involvement of the brain in the spinal cord, and
Right.
also involving the gray matter as well, the splenium of corpus callosum and the basal ganglia as well.
Mhm. Mhm.
Can be some demyelinating process. I want to see the post contrast images.
Post contrast images. These are the post contrast images available to you.
on post contrast, some of the lesions are showing incomplete
Mhm.
incomplete ring enhancement is there in the
Actually,
some of.
actually, they were the same on the pre-contrast images. The same signal intensities are there.
Okay.
So you can consider that non-enhancement.
Yeah.
Yeah.
So
So please conclude your findings and tell me what's your primary diagnosis and differential diagnosis in this case.
um, some demyelinating summing up in all these findings involving the brain as well as the spinal cord. Uh,
Mhm.
there is some demyelinating processes going on within the brain and the spinal cord.
Mhm.
So this can be um, acute disseminated encephalomyelitis, but that is more common in the pediatric age group.
Mhm.
Uh, and the multiple sclerosis, other differential, but in multiple sclerosis, the
Mhm.
some variant of the multiple sclerosis can involve the long segment of the cord. That can be the other differential. And um, to confirm my finding, the CSF analysis with the that will show the oligochronal bands
Mhm.
uh, that can confirm the diagnosis. Or
Okay.
in case of the acute disseminated encephalomyelitis, the anti-MOG antibody that can also confirm the diagnosis. And most likely the case is my principal diagnosis in this case is the multiple sclerosis with some variant uh, or less likely possibilities of the other demyelinating process cannot be excluded out.
Okay.
Uh, and this
Okay.
need
Any tip from the patient's clinical data or history could help you to confirm or exclude one of your differentials in here?
there is some tingling, there is some sensory symptoms were there. So uh,
Yeah.
um, there
The
may be
symptoms
some
are
light.
only the ones that I told you already. Nothing to add. What else in the history can help you?
If there is a relapsing remitting course of the disease is there, that can suggest the
Mhm.
multiple sclerosis, or the
Mhm.
monophagic illness is there that is in the favor of the Adam.
Okay.
Uh,
Okay, right. So please let me take over for the time factor. Um, you've done very well actually in describing and concluding. I would like only to add a few points in here. So these are your findings that you could describe very well. There is hyper intense signal in the bones medulla, and the cervical cord is in extensive hyper intensity involving more than 3-4 segments in here. And it's occupying more than two-thirds of the cord cross-sectional area in axial images with involvement of thalami, gray matter, as you said. So I will hold on that until candidate two participates with us. Candidate one, thank you for your effective participation. Actually, I would like candidate two to join us. Candidate two, can you hear me?
Yes, sir.
Yes. Hi, how are you? Doing good.
Yes, sir. Fine, Alhamdulillah.
Candidate two, I have this patient for you. Let me just share the images with you. Okay. Okay, just give me a second, please, to prepare the images. Right, so this is a patient who presented with exactly the same symptoms. He's a young patient. Okay, now you can see the sagittal images, I believe. He's a young patient who presented
Yes,
with numbness in the upper limbs. Please go through the images and tell me what you can see.
I'm presented with the sagittal T2 weighted images of an adult patient.
Mhm.
I can appreciate sir, images are not scrolling well.
Can you scroll now?
Yes, yes. I can appreciate there is an expansion of the guard at the level of C2 and C3 vertebral body with hyper intense signals, which is involving mainly the central and the posterior aspect of the guard. However, interior aspect is relatively spared. I can't appreciate any other focal signal in rest of the visualized guard. Cervicomedullary junction is normal, and rest of the vertebral bodies and another focus is seen at the cervicomedullary junction, small focus. I would
Right.
like to see the rest of the images like stir and post contrast images if available.
Yes, they are available. These are the post contrast images. Yep. Now you can see them.
Yes.
Yes. Can you see any enhancement in there?
Yes, subtle patchy enhancement seen in the central part of the lesion.
Central part of the lesion. Okay.
Yes,
So,
subtle ring-like enhancement and peripheral enhancement seen along the interior aspect of this area.
right. Well, so
So
what's the differential diagnosis at this stage?
it can be if the patient has the recent history of any flu and illness or fever, it
Mhm.
can be the acute disseminating encephalomyelitis. And if the patient has any sensory symptoms or tingling or motor symptoms, it can be the possibility of transverse myelitis. I would advise the entire neural axis images and MRI brain to see any other focus present in this. There is very less likely possibility of transverse myelitis because it is involving the long segment of the cord.
So you requested brain MRI images, and these are the brain MRI images. I would like to show you flare. Okay, now you can see flare images, right?
Yes.
Yes, this is actual flare images. Please tell me what your findings.
On axial flare images, hyper intense foci seen in the periventricular deep white matter, predominantly involving the peritrigonal regions.
Mhm.
Some of these lesions are perpendicular to the ventricles on the right side.
Mhm.
However, no subcortical lesions seen. I would like to see the posterior fossa structures like brainstem, and no corpus callosal lesions is seen. No lesion is
Because we would like
appreciated
to check for posterior fossa lesions.
because multiple sclerosis involve the midbrain bones and brachium pontis sometimes.
Yes, which sequence is the best to check for posterior fossa? And
T2 axial.
T2. Okay, these are the T2 images. Okay, can scroll through them.
Okay.
Yeah.
And T2 axial,
Mhm.
I can't appreciate any definite hyper intense signals or any abnormality. There is no volume contraction and the ventricle size is normal, and the rest minimal sinusitis is seen. However, rest of the structures and globes and nasopharynx appears normal. So in conclusions, I have first differential is the multiple sclerosis and the other possibilities acute disseminating encephalomyelitis. I would refer this patient to the neurology clinic, and I would compare with the prior images if available, and refer the entire neuroaxis for further evaluation.
Okay, right. So please stay with us. Thank you for presenting this case. I would like to take a minute to go again over it. So going back to the first case described by candidate one, again, there are hyperintensities in the bones medulla and extensive hyperintense signal in the cord, which occupies more than two-thirds of the cross-sectional area with involvement of thalami and the gray matter. Compared to your case, candidate 2, there are smaller lesions in the cervical cord. They are very subtle in axial T2 images. They involve less than a third or two-thirds of the cross-sectional area. They are more peripheral compared to the previous ones where they were central. So, and if you scroll through the sagittal flare images, you could see these lesions labeled in blue arrow. These are septocallosal interface lesions, which are very specific, actually, or highly specific, let's say, to certain disease entity. Other lesions are here shown in the yellow arrows. They are perpendicular to the lateral ventricles or the corpus callosum. And probably you can see that there's a central hypointensity within the lesions, better seen in SWI or gradient echo images, especially high resolution ones. It's called central vein sign. So the first case was ADEM, acute disseminated encephalomyelitis, and the second case was multiple sclerosis with Candida 2. So, what are the differences? How to differentiate between each of them? And you can use these to discriminate between the two in your daily life and in the exam, actually. And it's important to mention what you have and what you don't have in the images to make it easier for the examiner to evaluate and easier for you to reach the correct diagnosis. So once you see long cord lesions that are central, poorly demarcated with cord swelling, it's in favor of ADAM over MS, where there are short peripheral, less than 50% cross-sectional area, and not much of a cord swelling. In the brain, the cortex and gray matter are involved in ADAM, but they are less likely to be involved in multiple sclerosis. Actually, new reports say that some lesions involve the gray matter in multiple sclerosis, but they are not as much as common as in the ADAM. And the ADAM lesions are larger than multiple sclerosis in the brain. Otherwise, it's negative for everything that shows in multiple sclerosis, which is periventricular, perpendicular to the corpus callosum, calloseptal interface like those ones shown here in the blue arrow, and the central vein sign. It's better to be seen in SWI, high resolution images, and black holes. Black holes, which sequence do you see black holes?
T1 sequence.
Yes, correct. So more findings are there in the images, but these are the most important ones, and they are very quick, short checklist that you can go through in a very short time during the exam and score in the exam very well. Moreover, you can ask the examiner about the history. If the patient has a monophasic course or it's a multiphasic course, this is the first presentation, or he had previous previous incidents like that. One more thing that you mentioned really well is presence of a previous infectious process, for example, or vaccination as well. It's not uncommon for young adults also to have ADEM. They can have ADEM after viral infection, after certain vaccinations. They are at risk. Of course, they are less than the pediatric population, but it can happen. And this is the case happened here. It was a case of ADEM in the first case, and the second case is a case of multiple sclerosis. In case of ADEM, also check for any hemorrhagic lesions. If there are any hemorrhagic lesions or any hemorrhagic foci in the lesions of ADEM, this is a fulminant type and this emergency, and you should label it in the exam. It's important, actually. There is percentage of people involved in ADEM. They progress into multiple sclerosis. You might be asked about this percentage. It's roughly about 1/3 or 35%. So 35% of patients with ADEM should be followed up because patients of ADEM should be followed up because 35% of them might progress into multiple sclerosis. So follow up until resolution of the lesions is one of the important steps in the management of ADEM patients as well. Otherwise, as you mentioned, MS patients, we should inspect the previous images and compare between them if there are any new lesions or if there is an enhancement in one of the lesions present in the recent scan. It means that there is an active process. Okay, candidate 2, I'm going to present the second case for you. Okay, so this is a patient who came with left side weakness and numbness. Okay, I will start with the T2 images with you. Okay.
Okay.
Okay. You can spot the images now, correct?
Yes.
Yes, please go through them and tell me your findings.
It is the T2 weighted axial images of the of the brain. The patient present with a left-sided body weakness.
Yeah.
I would scroll from the caudal to cranial to the caudal direction till the last cut. Then I will explain my findings. In these images, I'm not able to appreciate any definite, but I will definite abnormality, but I would review it. Ventricles are normal in size, signals are normal, only a prominent incidental finding of VR spaces, subtle prominence of the temporal horns of both ventricles, which is likely normal for this age.
Would you like to check other sequences?
Flare, flare axial if available.
These are flare images. You can scroll through them.
Okay. On flare images, I can appreciate hyper intense signals, which is involving the gray and white matter, predominantly in the right frontal region, in the high parietal region.
Okay.
No associated edema in any mass effect is seen. Some hyperintense foci are also seen in the periventricular white matter, which suggests small lacunar infarcts. So I'm concerning for the infective changes. I am concerning for the ischemic changes in the right frontal and the parietal lobe. I would like to check. I will check the sinuses. If the sinuses appears normal flow wides, and I would check the status of the diffusion weighted images to see it's an acute ischemic changes if show restriction on the diffusion weighted images.
These are the diffusion weighted images. You can scroll through it.
Okay. And diffusion weighted images, I will check the area of abnormality. Yes, this area shows the restricted diffusion. So I would like to see the corresponding ADC value. If it is a low on ADC, then it is an acute ischemic changes.
Yeah, ADC is low.
Okay, these are the acute ischemic changes in the involving the territory of right MCA.
Right. So this is in the territory of the right MCA, you said, right?
Yes, I will inform the stroke team for the further management of this patient.
Okay. So any further imaging that you'd like to add to the patient?
Post-contrast images are available.
How would it help you, the post-contrast images in these patients?
I can like to appreciate any mass lesion or any enhancement in this area is present or not.
There is some enhancement in this region. How do you read that?
There is an enhancement in this area
Mhm.
There is a possibility the previously described hyperintense signals on the flare suggest an edema, and this enhancing focus, it can be the focus of any neoplastic etiology like metastasis, or it can be the area of leptomeningeal enhancement, which is causing the surrounding edema.
Right. So, what's your main diagnosis and the differential diagnosis here?
Keeping in view the post-contrast images, it's likely a metastatic focus. So next, I will advise the CT chest, abdomen, and pelvis to rule out any primary if the patient already not known. And I would ask the previous any imaging if available if the patient already known about the disease.
Right. Right. So, let me take over. Thank you, and please stay with us. Right. So, this is the patient that you've seen. And if you go back through the images, the base of the skull at the level of the internal carotid arteries, these are the vitreous portions of the internal carotid arteries. The green arrow is pointing to the normal left side, and the right arrow is pointing to the diseased right side. As you can see in T2L images, there is loss of signal void on the right side with loss of signal void also on the T1 weighted images on the bottom, and on the upper right this is the post contrast T1. You can also see that there is also the loss of the post contrast signal void on the right side. So your first diagnosis was the correct one. Actually, these are multiple infarcts in the territory of the right middle cerebral artery. But they are scattered one. They are scattered lacunar infarcts rather than a large area of large vessel occlusion. This indicates showering emboli. This internal carotid artery here is thrombosed, and it's sending small emboli to the terminal vessels or arteries in the territory of the right MCA. This contributes to the appearance of restricted diffusion and hyperintensity on a flare that you could spot at first. So the deceiving thing in here was the enhancement that you could see in the post-contrast images. If you remember the first case we talked about, there is some leptomeningeal enhancement that can happen in patients of infarction, especially in the subacute stage. And since these emboli are going like showering and they showed some restricted diffusions, if you correlate between them, you could see that the ones that are restricted aren't the ones that enhancing. The second thing is that the enhancing lesions that you could see are leptomeningeal, but they are crowded and they are not the restricted ones. So it means that they are in the subacute stage. Thirdly, if they were metastatic deposits, you expect to see them at the subcortical white matter junction, gray white matter junction, with extensive edema, which you excluded, and you said there is no edema surrounding them. Metastatic deposits usually have extensive edema for the size of the lesion. You can see a small lesion, but a huge edema around it. This is one of the features of metastatic deposits. Subacute infarcts can enhance. They are deceiving, and you should be confident of your diagnosis because you went through it systematically from the first spot. Okay.
Okay.
So, candidate 2, I would like also to show you a third case. This third case is for a patient who presented with left eye, decreased vision, and motion abnormalities of the left eye. I will start with T1 weighted images. Sorry, T1 weighted images. These are T1 weighted images. Can you spot them?
Yes.
Yes, please scroll through them and tell
I'm
me.
presented with the T1 axial images. The patient present with the left-sided motion abnormality of the eye. On the T1 weighted images, I can't see any focus of hemorrhage or any abnormal signals. Brain parenchyma is absolutely normal. Ventricles are normal in size. Structures through the orbit, visualized structures through the orbits appears unremarkable. Optic nerves, muscles, globes. I can appreciate the sinusitis only involving the frontal ethmoid and maxillary sinuses.
Yes. Let me show you T2, please. This is T2. Yes, please scroll through it.
And T2 weighted images.
Mhm.
Bilateral globes are symmetrical.
The globes are normal. You can skip them.
Okay.
And I'm not interested in sinuses as well.
Small deep white matter hyperintense signals which suggest small lacunar infarcts.
Forget that. Anything else?
I can appreciate there is an asymmetry between the both CP angles and
It's the patient tilt in the scanner. Forget that.
okay.
Okay, let me show you both contrast images. We had them done for, yes, we can scroll through both contrast images.
Okay. This is an axial post-contrast weighted images through the brain.
Yeah. Okay, can you go back to the level of the base of the skull? Yes, stay here. Here, this one. Yes.
I
Okay.
can appreciate an enhancing paracellular lesion, which is encasing the left cavernous sinus and
Right.
causing this is an extra axial lesion which is causing compression over the midbrain and also causing compression over the left temporal lobe. However, no abnormal signal seen within the brain parenchyma. It is completely occluding the left cavernous part of the left internal carotid artery.
Mhm.
I would like to see the coronal images, post-contrast coronal images.
Yes, they are available here for you. Yeah, you can scroll through this.
Okay, there is a redemonstration of this abnormality, which is I described on the axial images. It's an extra axial lesion.
Mhm.
It seems to be left paracellular meningioma, which is completely encasing the left cavernous sinus structures, maybe
Okay.
compressing the nerve,
Mhm.
maybe compressing the nerves which is passing through it, and that's why the patient feeling the symptoms of orbital symptoms.
What are the nerves that are passing through the cavernous sinus?
Third, fourth, and sixth nerves.
Okay, right. So your primary diagnosis is
Is
meningioma.
left paracellular meningioma.
Yes, and your differential diagnosis in this case?
It can less likely possibility of fungal infection or any extra axial lesion like leptomeningeal carcinomatosis or less likely possibility of metastasis, which is very less likely. The first differential in that case is meningioma.
Meningioma. Okay, so what's your next step of management?
I would refer this patient to the neurology and neurosurgery department for the further management.
Okay, thank you. Candidate number 2, please stay with us. I will get back to you. Candidate number 3, are you with us?
Yes.
Yes, candidate number 3, I would like to show you another case. Um, This is a patient also came with the same symptoms. Um, he had motion abnormalities on the right eye and some numbness in the right side of the face. And we had a brain MRI for him. I would like to show you the axial images. Candidate number 3. Can you hear me? Candidate number 3. Candidate number 3, can you hear me?
Uh,
Um,
I think the problem is unmuting. Just bear with me. We'll do.
it's okay. I'm trying to
I
unmute, but
think the candidate is not able to unmute. Just hold on, please.
okay.
I have been told that the problem is at the end of the candidate.
Yeah, if I may suggest,
So we can go to candidate 4, right?
yes, sure, no problem. We
We
can
can go
go.
to. Let's hope that she is able to solve that problem. Otherwise, you can use the other two candidates to show the rest of the cases.
Sure, no problem.
Divide
Sir,
them,
candidate number
divide.
4.
So candidate number 4, are you with us?
Yes, sir.
Yes,
So over to you.
most
Okay,
welcome.
sir.
Candidate number 4, this is a patient who presented with right eye movement abnormality and some numbness on the right side of the face. These are axial T2 weighted images for the patient. Please scroll through them and tell me your findings.
Okay, sir. I've been
Yep,
provided.
yep,
Sir, I asked for control.
yes, it's over to you.
Okay.
Yep.
So I've been provided with axial T2 weighted images, MRI brain.
Mm-hmm.
I will first scroll through the images. This is the most cranial image available. As I'm
Mm-hmm.
going caudally, I can see that there is abnormal signal intensity lesion, which
Mm-hmm.
is noted in the right cerebellopontine angle, and then it is extending in anteriorly into the medial aspect of the middle cranial fossa on the right side. The
Mm-hmm.
lesion is showing heterogeneous signal intensity, predominantly solid looking, with intermediate signal intensity and internal areas of cystic degeneration likely appearing hyperintense on T2 weighted images.
Mm-hmm.
Um, I can see that the lesion has is not originating from the vestibulocochlear nerve complex. It is slightly cranial to it. It is filling and expanding the Meckel's cave on the right side, and it is also showing slightly indistinct interface with the right cavernous sinus, intracavernous portion of right internal carotid artery. Depending on the location and extension from the posterior fossa into the middle cranial fossa and the well circumscribed margins, my top differential would be a schwannoma of the trigeminal nerve.
Mm-hmm.
And I would like to confirm this on post contrast sequences as well. Other differentials for paracellular lesion would also include meningioma. I can see that the signal void of the intercavernous portion of the IC is maintained, and there is no continuity, definite continuity with the lumen to suggest any aneurysm of the ICA.
Mm-hmm.
Meningioma is also another possibility, which I would confirm on the enhancement pattern. I could not see any significant bony hyperostosis.
Right.
Um, on the
These are the coronal T1 post contrast. Please scroll through them and tell me your findings.
okay, sir. So on the provided corneal T1 weighted post-contrast fat-saturated images, I can see that the lesion is showing heterogeneous but fairly avid enhancement, and the internal cystic components do not show any enhancement. There is no definite continuity with the lumen of the intracavernous portion of right internal carotid artery, and there is no dural tail sign. The lesion appears very fusiform, and because of the extension into two compartments, again, my differential is that of uh, trigeminal nerve schwannoma.
Mhm.
Yes, I will
So,
convey my findings to the referring physician. I would suggest a neurosurgical opinion for further management, and I would also take a look at the rest of the cranial nerves on this post-contrast image to see if there is any multiplicity of the lesion to rule out the possibility of any phacomatosis or neurocutaneous syndrome.
right. So, can you tell me if the lesion is extending extracranially or through any foramina in the base of the skull?
Okay, sir.
I know
So
it could be
yes, I can see there is extension to the foramen ovale. There
Mhm.
is widening and expansion of the foramen ovale, and the lesion is extending to the V3 segment of the trigeminal nerve. Um,
Perfect. That's perfect. Thank you, candidate number 4. Please stay with us. I get back to you. I just need
okay.
to uh, go through the cases that's described. Okay, right. So these two cases, they look similar, but with some differences in them that changes the whole diagnosis. It's important to mention these differences in your report and during the exam. Now, as you can see here, this red arrow is pointing to the left internal carotid artery, specifically to the cavernous segment. The lesion here, the enhancing lesion, is seen to invade the left cavernous sinus and encase the left internal carotid artery in there. Moreover, on the right side image, you can see that the blue arrow is pointing to the broad base, dural base in here. The lesion is dural based, which is broad. This is a feature of a meningeal-based lesion. And you can see here some enhancement along the dura, which is the dural tail, you can call it. So this is a lesion, dural-based, invading the cavernous sinus, encasing the internal carotid artery with a dural tail, extracranial, or extraaxial lesion. So as described by candidate number 2, this is a meningioma. The second case described by candidate number 4 is a lesion that is more heterogeneous, as you can see. There are foci of central cystic component and extracranial extension through the foramen ovale, which is widened, and this is typical for trigeminal schwannoma. Candidate number 4, can you tell me that the green arrow is pointing to which structure?
Meckel's cave.
Yes, exactly. And it's obliterated on the right side, which means that the lesion is extending into Michel's cave, and that also is a sign of trigeminal schwannoma. Candidate number 4, what is the yellow arrow is pointing to?
So this is probably the cavernous segment of the
Yes, this is the
ICA. Yes.
cavernous. This is the cavernous sinus. As
Hmm.
you can see, this is the cavernous sinus, and also it's obliterated on the right side because it's compressed, but it's not invaded. The internal carotid artery on the left side is seen here, and on the right side is seen here, opposite to this lesion, where the cavernous sinus is invaded by the lesion, and it's encircling the internal carotid artery uh, at the most distal part of the cavernous segment and the supraclavian segment, probably. So this is the first one is a case of meningioma. Second one is a case of schwannoma. So how do you differentiate between them? It's important in your daily practice and in the exam to mention these different findings, whatever is present and absent. So it would make it easier for you and for examiner to know that you know what you are looking at. So the trigeminal schwannoma is dumbbell shaped. It's hyperintense to gray matter. It's heterogeneous and heterogeneous enhancing. There are cysts more commonly seen than meningioma, and there is a target sign. Calcifications are rare compared to meningioma. A dural tail is rare or even absent, but if you could spot a dural tail in a schwannoma, it doesn't mean it's a meningioma. It can happen, but it's very rare. It expands bone rather than bone hyperestosis in meningioma and expands foramina, while meningioma narrows them. And it has a higher ADC value, which means less diffusion restriction compared to meningioma. Meningioma is cellularly compact, so it shows some restricted diffusion, especially if it's atypical. So other findings that you should search for in the available images is the muscle atrophy. If you can see some muscle atrophy and the masticator muscles, it means that it's more likely to be a trigeminal schwannoma or a schwannoma in general rather than a meningioma. Meningioma, it doesn't tend to cause the muscle atrophy. It's less likely to do so. Okay, so candidate number 4. I would like also to show you this case. This is a patient who presented with facial spasm. Okay, he's a young patient. He presented with facial spasm. Just a second to prepare the images for you. Okay, I would like to show you which sequence would you like to start with?
There's this sequence,
Which one, sorry?
T2 or heavily T2 weighted cis sequence.
Okay. We don't have CIS for this patient.
Mhm.
Or okay, we have CIS for the patient. Let's start with it, no problem. This is the CIS for the patient. You can see the images and scroll them.
Okay, so I've been presented with axial cis sequence of a patient who has presented with right-sided facial spasm.
Mhm.
I am looking at the vestibulocochlear nerve complex and
Mhm.
also the posterior circulation vessels to see if there is any lesion associated with the nerve complex or if there is any vascular loop.
Mhm.
Now I'm looking, so there is no definite focal lesion in
Right.
relation to the seventh nerve on either side.
Mhm.
I cannot see any. There is a vessel which is noted in the right
Ignore.
cerebellopontine angle,
Yeah,
but
please ignore.
but sorry, yes sir. I'm now looking at the internal ear structures,
Mhm.
which appear to be symmetrical bilaterally.
Right.
If a patient has facial spasm, I would
Mhm.
also like to look at post contrast images to see if there is any abnormal enhancement in relation to the uh,
Oh,
facial nerve
yes.
course.
Before you go to post contrast images, I would like to show you the sagittal flare images. Please scroll through them and tell me your findings.
Okay, so I'm scrolling through the sagittal
Mhm.
flare sequence,
Mhm.
and on the inspection, I do not see any obvious lesion
Mhm.
in the brain stem. There is no obvious pathology.
Right.
Yes, but
Okay. So let me show you something in here. I want you to search for a pathology in this image. Can you spot anything?
yes. Okay,
Yeah.
yes. In the provided sagittal images, I can see that there is likely an intradural extramedullary lesion in the anterior aspect of the proximal part of the cervical spinal cord at the level of C2. It
Mhm.
is fairly isointense to the brain parenchyma. I do
Mhm.
not see any internal cystic change,
Mhm.
and I also do not see any evidence of low signal around the margins of the lesion. I
Right.
would like to look at Excel images to see if there is any extension into the neural foramen.
Yeah.
And
The axial images didn't cover that area. It was outside of the brain, and the images requested were a brain MRI. So anything else that you'd like to do for this patient?
Um, on these provided images, the differentials would include a
Mhm,
meningioma or a nerve sheath tumor.
mhm,
And
mhm.
yes, I would like to look at the entire neuroaxis to see for multiplicity of the lesions, and also to see for
Yes.
any yes
What if there
for
were multiple lesions? What would you think of?
multiple lesions, like if these are multiple meningiomas, this could be in keeping with neurofibromatosis type 2. But if there is extension to the neural foramina and there are multiple lesions associated with the nerve roots, I would be thinking in lines of neurofibromatosis type 1.
Right. So, are you aware of any other disease entity or any other exposures that can cause multiple meningiomas?
Radiation exposure can cause multiple.
That, yes, correct. Okay, can radiation exposure cause any other multiple benign lesions in the brain?
um,
Are you aware of any association with any multiple benign lesions in the brain after radiation exposure?
I'm not
Yes.
remembering anything, sorry.
Okay, right. So, okay, for this patient, we had cervical spine MRI to better characterize. I will show you the images. And for the time factor, I will go directly to the post contrast images. And here you are. These are the post contrast images. And this is the lesion. So, what do you think? Any other findings in post contrast images you want to add?
Yes, so on post contrast images, I can see that the marrow signal is quite low as compared to the signal of the
Skip
disc.
that. Skip that. Just focus on the lesion itself. If you need to
Mhm.
add anything else about the lesion, the button of
So
enhancement, any
the pattern,
extensions. Yeah.
yeah, the lesion is showing fairly uniform enhancement. There is
Mhm.
no definite neural tail sign, and
Mhm.
I can see that on the right side probably there is some extension to the neural foramen over here, this part.
Extension,
Sorry.
there is extension to neural fiber.
Ye-
I would like to
yes,
show you the axial T1 images. If you allow me here.
yes.
Okay, these are the axial T1 post contrast images, and here is the lesion. Can you see any extension into foramina here?
So on, yeah,
Yeah.
for me,
Okay.
yes,
Uh,
not here,
okay.
not here.
If
Yes,
it is
I cannot
extending
see.
to foramina, what would be your diagnosis?
If it's extending through the foramen, no, it's not extending the
Right.
this neural foramen. Yeah, there is a plane of
So
fluid
please,
between them.
please conclude your case and tell me your primary diagnosis and differentials, please.
Yes, for a solitary lesion which is in extramedullary but intradural in the anterior aspect of the spinal cord, in the presence of history of radiation, I would be thinking on the lines of meningioma, since there is no extension through the neural foramina.
Mhm.
And also, if the lesion is, I haven't seen T1 weighted image, so melanocytic lesion could also be a possibility.
Yes,
Or
it wasn't hyperintensity one, it was ISO to hypo.
okay,
So,
then most probable diagnosis would be a meningioma.
right, perfect. Thank you, candidate number 4. Please stay with us. Okay. So this is the lesion that we could see. It's a iso-intense to slightly hyper-intensity to weighted images. It compresses the cord and it's homogeneously enhancing in both contrast images. So as mentioned by candidate number 4, the lesion is extramedullary, intradural, and there is differential diagnosis for that. The differentiation between these three categories is important. And again, it's important to mention them in your report and in the exam to make it easier for you to reach the diagnosis and score marks. Even mentioning them is considered like scoring some marks at least. So intramedullary endodural lesions, they tend to expand the cord because they are part of the cord, they are inside the cord, while extramedullary intradural, they compress the cord or displace it, like the one we spot before a while in here. And the extradural ones are outside of the dura, so you expect them to compress and displace both dura and the cord. The intramedullary intradural, they symmetrically narrow the subarachnoid space, while the extramedullary, they widen the subarachnoid space at the lesion site. If you can see here, the subarachnoid space is widened at the side of the lesion while it's compressed on the other side. This is a sign that is in this category, in the extramedullary intradural. The extradural, they narrow the subarachnoid space on both sides actually. Differential diagnosis for intramedullary intradural are meningioma, ependymoma, astrocytoma, and hemangioblastoma. These are the intramedullary ones: ependymoma, astrocytoma, and hemangioblastoma. These are the common ones, although we can see some others, like for example, demyelinating plaques, or like the ones that we saw earlier. The extramedullary intradural include meningioma, schwannoma, and Drobmets. Keep that in the differential diagnosis. Even in that case, even it was very well defined and it was homogeneously enhancing, no destruction of anything else, keep Drobmets in your differential diagnosis list. Extradural, as you know, they are metastatic deposits, degenerative changes, epidural abscess, hematoma, and many others. So the differentiation between them is important in your daily practice and in the exam to reach the proper diagnosis. So are there any differences between meningioma in the brain and in the spine that you might expect and you might be asked about as well? In the brain, hyperestosis is more common to happen in association with meningiomas rather than in the spine. It's rare in the spine to see hyperestosis, but if you see a meningioma in the brain, you should look in CT scan images and brain in the bone window and to look for hyperestosis, or at least mention that to the examiner. Calcifications, it happens elsewhere in the brain meningiomas, but they are more common in the spine meningiomas. So look there for them in both cases with more focus in the spine images. As our colleague candidate for mentioned, if there were multiple, I should expect either neurofibromatosis type 2 or radiation exposure. These are the common entities that you should mention in the exam as well. Candidate number 4, what other lesions you expect to find in F2?
There are multiple chordomas, multiple
Yes.
meningiomas, and multiple ependymomas. And if they are bilateral vestibular schwannomas, it is pathognomic for NF2.
Yes, excellent. So we expect to find meningiomas, schwannomas, and ependymiomas, and not only in the brain, but also in the spine as well. So you have to scan the whole neuro axis to look for these lesions to exclude multiplicity and syndromatic associations. Right. So now we are continuing with candidate number 4 for the next case.
Ahmed, how many cases for candidate number 4 are left out of the three?
Yes, a 3 as well.
Three are finished or three, there is something left?
There is one more case for candidate 4 now, and we
Okay,
have
so
4 cases for the last candidate.
sure. So if the candidate 3 cannot unmute, there is a technical issue
Yeah,
for candidate 3. So you will still have three cases left. Then you can divide them equally among all of them. Are you with
sure.
me?
Yeah, sure, I agree. Sure, no problem.
But we will ask the candidate 3 at that point after your case. Okay then?
Sure, Dr. Sami, no problem. So, candidate number 4, we are again showing this patient. Can you see my images?
Yes.
Okay, perfect. So, this is a patient who came with right eye pain, and we did orbit MRI for him. And these are the images. Over to you.
Okay. So I've been provided with the focused field of view MRI orbits in the T2-weighted sequence.
Mhm.
These are not fat suppressed.
Yep.
As I'm scrolling through the images,
Mhm.
I'm first focusing on the cavernous sinuses.
Mhm.
The fluid signal within both the cavernous sinuses is preserved, and also both the intracavernous ICs show preserved signal void. Now
Mhm.
I'm looking at the orbits. I can see that there is slight proptosis on the right side as
Right.
compared to the left side. The globe, however, maintains its intact profile. The lens is normal in position. I do not see any vitreous abnormality, any abnormal signal. The visualized extracorneal muscles appear to be slightly asymmetrical. They are prominent on the right side and show slightly appear hyperintense. Could be
Right.
secondary status changes along with proptosis. I am trying to look at the superior ophthalmic vein, if
Mhm.
it is showing normal signal, whether it is distended or not.
Okay.
Wait, trying to go to the top. Um, I'm sorry, I'm scrolling in the opposite
So,
direction.
yeah, ophthalmic vein is normal. I would help you with these images. Please allow me to
Yes,
show you more images
yes,
here.
sure.
Okay. These are the fat suppressed images at the same level. What do you think?
Okay. So as I'm scrolling, I can see that the fat appears slightly heterogeneously hyper intense on the right globe and the right orbit as compared to the left side.
Right.
Other than that, yes, with the proptosis, mild edematous changes in the muscles and also some heterogeneity in the fat.
Mhm.
I would think on the lines of some inflammatory etiology, which is involving different compartments of the right orbit. Um,
Right.
so if the patient has acute symptoms and it is painful, I would be thinking of IgG4 related pathology.
Mhm.
Um, Yes, otherwise, there is no specific involvement of the muscles or of the optic nerve, which would point towards other etiologies. Um,
Right. So these are the post contrast images, a T1 fat sat, post contrast.
yes.
What do you think?
So on the post contrast images, again, there is some heterogeneous enhancement in the intracorneal fat. And also, I'm looking at the sclera, it is enhancing normally bilaterally, and
Right.
there is no evidence of any subperiosteal abscess.
Yes.
And no definite the signal void of the intracavernous portions of IC is maintained. I do not see any thrombosis there. So I would be thinking on the lines of inflammatory process, likely IgG4 related disease.
Mhm.
Other
Mhm.
differentials would include inflammatory pathologies like neurosarcoidosis or
Okay.
sarcoidosis involving the orbit. Um,
Perfect. So what's your next step in management?
The next step would be referral to the neurology unit, and I would suggest an ophthalmology review as well, and correlation with IgG4 levels, and response to corticosteroid treatment.
Mhm. So your primary diagnosis is orbital pseudotumor, is that correct?
Yes, considering I would be focused on the clinical symptoms as well.
Yeah.
If the patient has presented acutely with painful proptosis, then I would be thinking of inflammatory etiology. Less likely possibility of lymphoproliferative disorder is always there. Um,
Yeah.
yes,
So any other associated pathologies with orbital pseudotumor are you aware of? If you can mention two or three.
Yes, IgG4 related pathologies can involve multiple organ systems, including the salivary glands as well. Then there could be involvement of thyroid gland,
Mhm.
mediastinum. There could be involvement of the hepatobiliary system with the sclerosing cholangitis, autoimmune pancreatitis. There could be retroperitoneal fibrosis.
Okay.
Um, these are the things I can think of.
Right. Okay. Thank you, candidate number 4. We would like to check with candidate number 3 again. If candidate number 3 can unmute. I think yes. Yes.
Candidate number 3, are you with us? I can
I
we
can see that candidate number 3 is
yeah, I can see that unmuted, but we cannot hear candidate number 3. Candidate number 3, can you speak up, please? I'm sorry, we cannot hear you, so there must be some technical issue at your end. So, Ahmed, now what we will do is that candidate 1, are you with us?
Yes, sir.
And candidate 2, are you with us?
Yes, sir.
So, Ahmed, you have got 3 cases, one for candidate 1, second is for candidate 2, and the third one is for candidate 4.
sure. So candidate 1,
Apologies, candidate 3, maybe next time. I think there is a technical issue at your end. Okay, Ahmed, please carry on.
thank you, Dr. Sani. So candidate 1 will come back again. This is another patient with orbit MRI. The patient came with a complaint of bilateral eye pain and difficulty in movements. So over to you, please.
Here I am presented with the MRI orbit axial section T2 weighted images of a patient who has eye pain complaint. Here I can see that bilateral symmetrical lobular enlargement of the bilateral lacrimal gland is noted, which is hypointense on hypo to isointense on T2 weighted images. Lesion is involving extracorneal compartment of eye. Uh, or optic nerve appear normal and extraocular muscles appear normal. So, uh, I want to see the T1 weighted images as well.
Yes, sure. These are the T1 weighted non-fat SAT. Okay, and I will help you too with coronal T2 images. I would like to pause on these images and please tell me what you see in here.
I want to see the lacrimal gland area.
Okay, these are the lacrimal glands.
Yeah,
Okay, can you see them here?
yeah. I can see that. Yeah, there is enlargement of the lacrimal gland is there,
Right.
and that is
What about this slice or section of the images? Can you spot any pathology in here, any findings that attract your eye?
mm,
What do you
uh,
think about the extraocular muscles here?
they look slightly bulky.
Which
Uh,
ones?
the inferior rectus that is more bulky.
Okay,
Uh,
what
So, and then the medial rectus and superior rectus and rectus is less bulky.
lateral is, let's say, spared. Is that correct?
Yeah,
Okay. Are you aware of any pathology that can cause that bilaterally?
thyroid ophthalmopathy that can cause enlargement of the optic nerves, especially enlargement of extraocular muscles with sparing of the tendon sheaths.
Yes, exactly. These are the post contrast images. As you could spot the lacrimal glands. These are enlarged and enhancing here. And if you can see the extraocular muscles, they are enlarged and enhancing with the sparing of the lateral rectus muscles bilaterally. So please conclude your findings, diagnosis, and differentials, please.
This can there is some systemic processes there that is involving the extraocular muscles and the lacrimal gland.
Mhm.
Uh, this is due to the thyroid ophthalmopathy due to Graves' disease,
Mhm.
and other differential for this the can be the pseudotumor, but that is unilateral and that presented with the pain. And in the here the extraocular muscle enlargement is there, so the possible complication can be that due to the bulbous enlargement of the extraocular muscle can lead to the optic nerve compression. That should be ruled out. And ultrasound, and then the endocrinology and the ophthalmological referral is indicated. And
Mhm.
anti-TPO antibodies, uh,
Mhm. Yeah.
they yeah.
Right. Perfect. So your conclusion was correct and well organized. Thank you, and please stay with us. The second case that we showed just now, it shows the yellow arrows are pointing to the moderately enlarged and enhancing in the post-contrast images, medial and superior rectus muscles. The most involved is the inferior rectus muscle, which is pointed to by the red arrows. The green arrows point to the spared, relatively spared lateral rectus muscles bilaterally. In the inferior images on the left side, you can see here the arrows point to the lacrimal glands, which appear enlarged and enhancing on the right side image next to it. This appearance of muscle enlargement would include with sparing of the tendon. Actually, they resemble it to Coca-Cola bottle. Some books and articles refer to it as Coca-Cola sign. Just to remind you of it, it doesn't spare. It doesn't involve the tendons, so it spares the tendons. On the other hand, the case before that was the pseudoorbital tumor. It showed diffuse enlargement and abnormal signal of the extraocular muscles with involvement of the tendons in there. There is some retroorbital fat stranding and enhancement in post-contrast images, and it's usually unilateral. So, another differential diagnosis that should be included in both cases is orbital lymphoma. It's important to mention that and to differentiate between the three. Orbitopathy is usually symmetrical, bilateral. Orbital pseudotumor is only unilateral, and orbital lymphoma is bilateral, not necessarily symmetrical. The tendon is spared in both lymphoma and orbitopathy, thyroid orbitopathy, but it is involved in the idiopathic orbital inflammation, is the new name for the orbital pseudotumor. Muscles involved in the thyroid orbitopathy are better remembered by IAMS law, which is inferior, most likely, then middle, superior, lateral, oblique, and the lateral and oblique are the last ones to be involved. These are non-specific orders in the other differentials. Thyroid orbitopathy causes proptosis, while pseudotumor causes dirty fat, and orbital lymphoma causes molded soft tissue lesion that goes around the structures in the retroorbital space. The only one painful is the pseudotumor. Lacrimal gland involvement happens in all of them, but it's more common in the orbital pseudotumor and in the lymphoma. The thyroid orbitopathy is less likely to involve, but it wasn't the case that we presented. The case that we presented, it was involved the lacrimal gland, and they were bilateral, but this is not the common presentation. So, per presentation, it's more acute in the orbital pseudotumor, while it's more insidious or progressive in the other differentials. One important point to remember and to look for and to mention in the exam, if you could see the lesion that has very low ADC value, that is very restricted, think of lymphoma. Think of lymphoma first. It is the lowest ADC among all other differentials, while others have intermediate to high ADC values. This is very discriminatory for lymphoma, and it's important to look for and to mention in the exam. Most of them, they respond to steroids variably, but orbital solid tumor shows the most response to steroids. So it's important also to check for optic nerve compression, and I believe in the case that we showed, there was some optic nerve compression on the right side. It's not really evident, I know, but it's worth mentioning and checking for in the exam at least. And also check for sinusitis. It could be an inflammatory process extending from the sinuses into the orbits, and it would change your diagnosis. So we would move now again to candidate number 2.
Yes, sir.
Candidate 2, yes, are you with us? Okay. I have a case for you, and this patient came with headache. Okay, patient came with headache. Just a second until I prepare the images for you, please. Mm, it will take just a second to upload. Please bear with me. Okay. So, right. So you can see the brain CT scan images, right?
No, sir.
Yes, please, you can scroll through them and tell me your findings.
Sir, not able to see the CT slices.
Just a second. Okay, now you can, right?
Yes.
Yes. Okay, please go through them and tell me your findings.
These are the axial sections of the non-contrast CT brain. The patient present with headache.
Mhm. She's a
Uh,
young, by the way, she's in early 20s.
okay. There is no foramen magnum crowding and the base of skull appears normal.
Anything else? Let me help you out with targeted questions. Can you see anything in the sulci ventricles?
Okay.
Yeah. So if it is normal in the exam, just tell the candidate that you cannot spot any pathology and proceed to the next image. The examiner might guide you through. So in this case, can you see any pathology in the brain? Anything that you can spot?
No significant abnormality as the sinuses appears normal. No hydrocephalus seen. Gray-white differentiation seems normal. No evidence of hemorrhage.
Yes. So
Posterior muscle
you
structure, base of skull appears normal.
what would you do?
Next, I would advise MRI.
Yes, MRI. Please let me upload the MRI images for you. Okay. Which sequence would you like to start with?
Axial flare images are available.
Axial flare. Okay, just a second. These are the axial flare images. Please scroll through them and tell me your findings.
These are the axial flare images of the same patient in which I can appreciate hyper-intense signals, which is involving the right sylvian fissure and the sulci of the right frontal and the parietal lobes,
Right.
which is extending up to the level of high parietal region. So I'm these are flare hyperintense signals. Next, I would like to check the T1 sequences. I am suspecting hemorrhage in this area, which can be a pus, but I would confirm on the T1 weighted images.
Okay, these are the T1 weighted images.
On the T1 weighted images, these areas are still hyperintense.
Okay. Are they specific to the site that you already mentioned before, or you can see T1 hyperintensities on another side as well?
Yes, I am also appreciated on the other side as well. So it's
Okay.
consistent with the subarachnoid hemorrhage.
Mm-hmm. Mm-hmm. So please bear with me. Let me show you the T2 weighted images. These ones. Okay. What do you think at this level, at the level of the base of the skull or the lower brain? Can you see anything in here, anything that attracts your eye? Nothing much, right? Okay,
Yes.
so basically that now your primary diagnosis
Is a
is
subarachnoid hemorrhage, I would ask the patient history of trauma. If it's not present, then it's a non-traumatic subarachnoid hemorrhage. Then I would advise a CT angiogram
okay,
to see any aneurysmal rupture or any other vascular tumor or something.
right. So this is the brain CT angio as requested. It would be difficult to spot any aneurysms in here, but anything else that you can see in these images. Let me help you with the coronal ones. These are the coronal ones. Can you see anything here? Okay, no worries. So basically, what differential diagnosis or other disease entities that can cause hyperintense flare signal in the cell site? Anything else other than subarachnoid hemorrhage?
It can be due to the meningitis, as meningeal thickening seems hyper intense on the flare images, but it is not hyper intense on the T1 weighted images. I would like to see the post contrast images. It will further confirm my diagnosis. If it enhances, then it's a leptomeningeal enhancement. If there is no enhancement, then it confirms the diagnosis of hemorrhage.
Mhm.
Gradient echo images can also help in this context.
Yes, right. Okay, thank you. Thank you, candidate number two. Please stay with us. For the time factor, I will have to take over to go through the case. Okay, so you can see this slice. This is the axial flare images that candidate two described very well. There were hyper intense flare signals in the cell side, in the right side of the brain, frontal, parietal, and Sylvian fissure. So in both contrast images and CT angiography, if you can see these red arrows, they point to the internal carotid arteries. They were really narrow. And even the middle cerebral arteries bilaterally, they were also narrow. And you can see that the blue arrows are pointing to them. So there is diffuse narrowing of the intracranial vessels. It can be seen actually with subarachnoid images, but there are other disease pathologies that can cause so. This is one of the images of the catheter angio that confirms the findings. Diffuse narrowing of the intracranial major vessels, internal carotid, and it was even difficult for the neurointerventional to catheterize the vessel. So the causes of hyperintensity in a flare in the cell site is not only limited to subarachnoid hemorrhage. You should broaden your differential diagnosis to consider the following. It could be fat, which causes which could be caused by ruptured dermoid, melanin, which can be caused by, for example, for melanoma or melanoma metastatic deposits. It can also be caused by meningitis since it causes increased permeability. Leptomeningeal myths also. Slow flow or signal voids in the sulcal vessels in cases of acute stroke and moya. Artifacts like in hyperbaric or high inspired oxygen anesthesia agents also can cause that. Gadolinium from previous injection can last for some time and can cause that. So candidate number two, after looking at the differential lists with the narrowing of intracranial vessels in a young patient, which one of these differential lists would be more likely? Candidate number two,
In,
can you hear me?
in Moya disease, there is extreme narrowing of the internal carotid arteries and the middle cerebral arteries.
Excellent. I'm not expecting you to reach the diagnosis actually from the first image, but at least to consider these differential diagnoses if you are presented with hyperintense T1 or flare signals in the sulci. It's important actually to consider these differential diagnoses. Okay, candidate number three, the last case is for you. Are you with us?
Yes, sir.
Yes, perfect. So candidate number three, this is the last case. Just a second until I prepare the images for you, please. I'm truly sorry for taking a little bit more time than it should
Yeah.
be, but we will go through this case a little bit faster. And okay. I know it's very late at some place where our colleagues are attending. So, candidate number three, can you see my screen?
Yes, sir.
Yes, this is a young patient. She is 10 years old. She presented with bilateral lower limb weakness and upper limb actually. These are the sagittal T1 fat sac post-contrast images. Please scroll through them and tell me your findings.
Okay, sir. I will
Okay,
test it.
this is over to you, please.
Okay, so I've been presented with T1 post-contrast sagittal fat set sequences of MRI cervical spine of a young patient who has
Mhm,
presented with limb weakness. On scrolling through the images, I can appreciate a well circumscribed, marginally enhancing intramedullary lesion in
mhm,
the cervicodorsal spine.
mhm,
Um, this is a solitary lesion that I can identify. I cannot see any additional lesion in the cerebellum, in the brain stem, in the
mhm,
cervical cord, and in the rest of the spine that I can visualize.
mhm,
I am trying to look at the leptomeninges to see if there is any nodularity or enhancement. I can see that there is nodularity and enhancement of the leptomeninges along the cord. These lesions, both intramedullary and leptomeningeal, point towards metastatic disease spread. For a young patient, I would be thinking predominantly of intracranial tumors, which could result in CSF seeding. These could be pineal lesions. These could be posterior fossa lesions. I cannot see any in the provided images, but medulloblastoma, ependymoma, choroid plexus lesions, and pineal region lesions are all sinister for causing metastatic disease process. So
mhm.
I would like to suggest imaging evaluation of the entire neuroaxis, including the brain and the spine, with contrast to see for the primary lesion and also to completely evaluate the metastatic disease spread. Um,
Right.
yes.
Perfect. Thank you, candidate three. Just one question. You asked for MRI with contrast for the whole spine. Are you aware of any lesions in the spine that can cause drop metastatic deposits like that, or only it comes from the brain?
Spinal lesions in a young patient.
Mhm.
Uh,
In general, ignore the age of the patient. In general, can you tell me if you know any lesions in the spine that can cause metastatic deposits, meningeal ones in the rest of the spine, or it's
append-
only the concept of a drop mets are lesions that coming from the brain only?
um, technically, I don't know, but I know that ependymomas are sinister, so I'm not sure if the spinal ones can cause drop meds.
Yes.
But that I know that CNS tumors. Uh,
Right. Right. Perfect. Yes, your thoughts are correct actually. Myxopapillary ependymoma, it happens in the spine, the distal spine, and it can cause the same appearance. So the concept of a drop mits is not only limited to brain lesions, it can happen also from spine lesions. Okay, thank you, candidate number three. Please stay with us for the rest of the discussion.
thank you,
Um,
sir.
Yep, I will go for these really quick, not to take more of your time. So, our colleague could spot these different tiny enhancing lesions in the spine. If you are only limited to this lesion and you started describing the intramedullary lesion and thinking about it, you are going through a different path. But spotting different findings, associations in the images can help you actually. So these are drop myths. The differential diagnosis in such a case, I would like to mention only two differential diagnoses for drop myths, meningitis and neurosarcoid. Let's focus on meningitis and compare it to drop myths and how to differentiate between them. Drop myths are nodular, as we could see, while meningitis causes smooth linear enhancement of the leptomeninges or the dura or